this is the posterior division here. So if you ligate that, then the superior gluteate artery, that artery is also going to reduce the blood flow, and that is going to cause certain amount of ischemia to the gluteus area and cause gluteal pain. Hi, welcome back to these deliberations, and we are now going to do the NEET 21 questions. The obstetrics and gynae paper was extremely exciting this time because they asked a lot of common topics, but they kept twisting all the questions a little bit so that they keep teasing us a little bit with the choices so that they can always, test whether we've been reading our basics to the limit where they can make us postgraduates. Alright, so I know we'll do these questions one by one and see what was so peculiar about all these questions. And I have tried to recall all the choices as close as possible to the ones which came in the exam. But if there's anything you want to suggest, you can always write me an email or meet me on the PrepLadder forum. Alright, so we'll start with first question. A 36 weeks pregnant lady with mitral valve replacement was on warfarin. Her INR value is 3. Next step in the management is. Now, they're trying to say that a pregnant lady is, at the time of 36 weeks and she may go into labor. And if she goes into labor, then the action of warfarin may last up to 5 days. So if she goes into labor, then she may actually start bleeding a lot. So that's why we say it's better we stop the warfarin and keep her on a drug which is, which when we stop is going to stop its action very fast. So warfarin will have a much longer action, something like up to even 5 days. But if you check things like the low molecular weight heparin, it will be something like 10 to 12 hours maximum, and the unfractionated heparin, that will last for something like 4 to 6 hours, isn't it? So if we are changing the patient on, let's say, on low molecular weight heparin, then around 24 hours before the expected induction of labor, suppose she's being induced at 38 weeks, so probably a day before we can stop the low molecular weight heparin and then induce her, and we'll be very sure that she's not going to bleed too much because of the action of low molecular weight heparin. Whereas if the warfarin is continued, it's going to be in the circulation for much longer time. That's why, so what we do, we stop the warfarin and start heparin. Okay, so the choice which is best here is stop the warfarin and start the low molecular weight heparin. So choice A is the best answer here. Continuing warfarin is wrong, and starting aspirin and heparin. Now, starting aspirin at this time of the pregnancy has no particular benefit. So between A and C, I'm definitely going to go with A. Continue warfarin, aspirin, that's obviously a wrong choice. So the answer for this question is A. So question number 1, I would say the answer is A. And let's move on to the next question. A pregnant lady has a history of delivering twins. If she is pregnant for the second time now, which one of the following is a obstetric score? So, when do we say a woman is a gravida? A woman is a gravida when she's pregnant. As of now, she's pregnant, then only we say gravida. Please, guys, don't be in a habit of calling a 65-year-old lady who comes to you with prolapse, having 3 live children after 3 deliveries. She'll be a para 3, live 3. She'll not be a gravida 4, para 3, live 3. Now, that's where we guys get wrong so many times. Till she's pregnant, don't put the gravida in the obstetric formula. So, yes, if she's pregnant, we say gravida, and if she's delivered a child, anything after 28 weeks, then we say she's attained parity. Alright, so yeah, in India it is 28 weeks. So that's the other place where you keep getting confused, because most of your Western books say 20 weeks, because they are able to save children who are born after 20 weeks quite a few times. We are able to save children only when they're born after 28 weeks. So let's not get confused with that anymore. For us, 28 weeks and beyond is viability. Okay. So if a child is delivered after 28 weeks, we can save that in our country. So yes, if she is pregnant for the second time, so that is a gravida 2, and she's delivered twins. They're not saying that she's delivered 2 times. They said she's delivered twins. That means she's delivered once, that is para 1. And she's got twins which are living now, so we say live 2. So yes, that's a pretty simple question. I was surprised that they could do this for you. So the answer is gravida 2, para 1, live 2. So answer is A. Okay, as simple as that. And there is sometimes confusion when people want to discuss the obstetric formula in a different way. You know, the one which I have told you right now is the gravida, para, and live and abortion system. This is the usual system which is always used in all the forums and wherever we are working and wherever you are getting any references in journals and in books. But yes, there is another system which is the GT-PAL, okay, GT-PLA or GT-PAL, whatever way you want to remember. So, they have just split the para into term or into preterm. That's the only difference, okay. This is not used very widely. This is used in some locales like Williams obstetrics would say. So, yes, you have just got the para. You know, if a baby is born after 28 weeks, that is para. But now, if it is born between 28 to 37, we say it is preterm. If it is born beyond 37 weeks, we say it is term. So, yes, that's the only difference between the GPLA and GTPAL syndrome. So, if you go through the systems once more, it is the gravida, para, live and abortion GPLA, or it is the gravida, preterm, term, abortion, live system, where the para is split into term and preterm. That's the only difference, and the one which is accepted is this one. So, with this question, like I said, I am going to go with the answer of A. It is a gravida 2 and she is delivered once and she is delivered 2 children in that delivery. So, that is why it is para 1 and live 2. Alright. So, let us move on and see that the definition given for the para is the time when a delivery has gone beyond 20 weeks by the Western books. Now, that is where we are getting a little confused every time we read these books. So, beyond 20 weeks is where it is wrong. We have to say beyond 28 weeks in our country. So, yes, do not go with this one. You know, I know the books to refer are the good books and Williams is an extremely good book, but data you have to know Indian. Okay. So, in some locales, the obstetric history is summarized as a series of digits connected by dashes. So, these refer to the number of term infants, preterm infants, abortuses younger than 20 weeks and children currently live. Okay. So, that is the system which I was telling you, that mostly we are going to follow the gravida, para, live and abortion system, but some places the para is split. Alright. So, that was some proof which I was trying to show you, that it is used in some locales and not very widely. Okay. Question number 3. A patient on OC pills has missed 4 pills. What is the best advice to her? You know, I have taken 2 forms of this question so that we can discuss it both the ways, because there was a lot of ideas given to me by the students on the forum. So, yes, a patient on OCPs has missed 4 pills. What is the best advice to her? Take next pill as soon as possible and consider alternative contraception like a condom or emergency contraceptive if the patient had intercourse within the last 72 hours. Now, this one seems to be the right answer, because take 4 pills as soon as possible, that is never going to be the answer. Never have to give more than 2 pills whenever a woman has missed 1, 2, 3, 4, whatever number of pills. If you want to start giving pills next, then it can never be more than 2 pills. The pill which she has forgotten and probably an extra pill, that is all. You do not have to give more than 2 pills anytime. So, that is why this choice B is wrong. Stop the regime and adopt another method of contraception. In this format of question, this is not the right answer. Discard the pack and start the new pack of pills. Again, that is wrong. So, the answer which is most probable, answer is A. Take the next pill as soon as possible and consider alternative contraception, because she is missed for 4 days. Now, why I said alternative method? Because whenever OCPs are started, you know, when you start the OCPs, 7 days, it takes 7 days for the action to set in. So, for the OCP action to set in, it takes 7 days. So, for that time, whenever you are starting OCPs for the first time for a lady, that is, she is married in September, and September 1st she had a period. So, let us say from 3rd of September she started a pill. For that first 7 days, from 3rd of September till the 10th of September, in that 7 days, she will not be protected. So, she has to take a condom or any other method of contraception, or avoid having intercourse for that matter, for that first 7 days. Now, when she is continuously taking the pill, like she is taking in September, October, November, December, January. So, January when she is taking the pill, let us say on 3rd of January again. Now, she does not have to take any other contraceptive method in the first 7 days, alright. It is not forever that for the first 7 days she has to take an alternative method. It is only when she is starting for the first time, alright. So, that is clear. Now, if the pill missed is in the first half of the month or the second half of the month, that's where also some more intricacies are there. So, let us discuss them. Now, if the OC pills are missed, 1 or 2, take 2 pills at the scheduled time. Okay, she's missed 1 day or 2 days. Whenever she remembers, she just takes 2 pills and that's the end of it. That's the easiest thing to remember. Now, she's missed 3 or more pills in the first or the second week of starting the tablets. That is, she started in September and in this first 1 week. So, in the time from 1st of September to 14th of September, in this she's missed 3 pills or more, then that is too much of a miss. So, what we say, take 1 pill and continue the pack. Take the pill. Today she remembers, oh, I forgot for 3 days. Okay, I take just 1 pill today and then continue the pack as it whatever is left. But remember, next 7 days, whenever a OC pill is missed beyond 3 days, whenever OCP is missed beyond 3 days, like 4 or 5 days, so 3, 4, 5 days if the OC pills are missed, then the contraceptive effect is gone. So, that's why now she needs to take another contraceptive method for the next 7 days, yes. And if she's had intercourse, she has to take emergency contraception also. Now, if she's missed 3 or more pills in the 3rd week, now 3rd week, the contraceptive effect is not going to wear off so easily. So, what we say, take 1 pill and complete the pack, but now don't give the gap between the 2 packs of pills. That is, throw away the non-hormonal contraceptive pills. I mean to say the pills which are the iron, the ferrous sulfate tablets in the OC pill pack, the 7 tablets which are inert and they are only having the ferrous sulfate. So, those she can throw and start the next new pill immediately. So, yes, if she is forgetting many pills in the last week of the 21 days, then she is going to take 1 pill, complete the pack and start the new pack immediately. So, yes, she is going to get a period very delayed this time, but that does not matter, she will be protected still. Alright. Now, the same question was asked in a different way as suggested by some students, that a 25-year-old lady was taking combined oral contraceptive pills for contraception. She gave history of missing 4 pills on different days in the past 2 weeks. That is, she just started the pack and she has missed the pill, at least on 4 occasions in the past 2 weeks. Now, that is a lot of missing when she is starting a new contraceptive method. So, yes, this makes us believe that this woman is probably not the best candidate to take the OC pill. Now, that's where the answer will change with the same choices, but the question is that she's missed 4 pills on different days. Then I say stop the regime and adopt another method of conception, because you're not reliable. You're going to miss this pill so many times and you're going to go on taking extra pills and go on altering the regime. And if you are not very comfortable in remembering the pills, and if it's a big task for you, then probably you can take an IUCD, where IUCD is that conception where you say fill it and forget it. So, once you put the IUCD inside, after that she doesn't have to remember anything. So, people who are not very well motivated, now that's where this motivation funda comes in from. Some of you get very confused when this motivation bit comes. When a person is not well motivated, like this situation, that she is not going to remember taking the pill properly, then it's best that we use a IUCD, because once you put the IUCD, after that you don't have to bother about conception for her. So, yes, that's the meaning of motivation. So, that she is not well motivated. So, give her the IUCD. Now, you don't have to remind every month, you don't have to remind every time she has intercourse to use a condom, or to come to the hospital for an implant every 1 year or 2 years. So, that's why when women are not well motivated, then IUCD is a good one, So, when we say she is not motivated, we mean to say she is not motivated for contraception. Don't say that she is not motivated for a IUCD usage. Now, that's where you got that funda wrong. Okay. So, please understand, when we say not motivated, she is not motivated for contraception. So, then IUCD becomes a good option for that. Okay. Anyway, so this question in a different way, if it was asked that she's missed 4 pills on different days within starting in the first month, she is not very reliable. Go ahead and give her another method of conception. Okay. Question number 4. A lady presents with history of recurrent abortions at 8 weeks, 11 weeks and at 22 weeks. She also had preeclampsia in the last pregnancy. Cardiac activity of all the 3 pregnancies were normal. Which of the following is the most probable cause? Now, when they are trying to say preeclampsia along with 3 abortions, I am straight away going to mark antiphospholipid antibodies syndrome, because yes, there is a suggestion that it could be syphilis. Yes, I am thinking about that, because syphilis has progressively better outcome. That if a person is having a pregnancy loss at 8 weeks, next time at 11 and third time at 22nd, probably the 4th time she'll have a live child delivered at 34 weeks. So yes, this can be also because of congenital syphilis, but yes, the association of preeclampsia is making me think more in terms of antiphospholipid antibody syndrome, because in addition to causing thrombus and fetal death, it can also cause thrombus little late in pregnancy, and to go push blood through the thrombus in the placenta, the mother has to increase the blood pressure. So yes, preeclampsia along with this history, I would think in terms of antiphospholipid antibody syndrome. Yes, it can definitely not be TORCH, because TORCH does not cause recurrent abortions. That's for sure. You know, for PG entrance exam, if TORCH is coming as a choice for recurrent pregnancy loss, just stay away from that choice. It can be gestation diabetes mellitus, but then it's more closer to the antiphospholipid antibody syndrome, because GDM causing abortions can happen obviously, but GDM classically causes intrauterine death at term. So that's why I want to say that it's not GDM that causes intrauterine death at term more likely. So that's why I would stay with APLA. So for the diagnosis of APLA, there should be clinical criteria, one vascular thrombosis, then pregnancy morbidity, and then there could be laboratory criteria. Please remember the lupus anticoagulant, anticardiolipin antibody, anti-beta 2 glycoprotein 1 antibody. All of these should be at least done twice and 12 weeks apart. Some books are saying 6 weeks, so let's not get confused too much about these. Okay. So what was that law about syphilis? That law is known as the Kasowitz law, and Kasowitz law says that if a woman with untreated syphilis has series of pregnancies, the likelihood of infection of the fetus in later pregnancies becomes less. So that trying to suggest that the outcome of a pregnancy is progressively better if there is syphilis. Okay, the subsequent pregnancies will be always better. Right. So we'll take question number 5. A 28-year-old married female anxious about conception with complaints of profuse white discharge with no history of itching, present on the 12th day of last menstrual period. Which one of the following is the most probable diagnosis? So yes, they're trying to say she's trying for a conception and she's around the 12th day of a menstrual cycle, and we know around 12, 13, 14 day the cervical mucus is thin and watery. It is stretchable a long way, spin bucket, and that thin and watery cervical mucus is going to help the transport of sperms. So yes, that is telling me that this patient is probably having a good amount of profuse vaginal discharge, right? She's having a vaginal discharge which is going to help the sperms swim through in this cervical mucus and reach the site of fertilization and fertilize the oocyte in the ampulla. So I'm very sure that this is a physiological discharge, and you know, they could have just said that she's got profuse white discharge on the 12th day, what it could be. So I'll say physiological, but they've also added that there is no itching. So yes, they're trying to suggest that it could be probably bacterial vaginosis, but they're saying that there is no other convincing suggestion that it could be bacterial vaginosis, because there is no mention of clue cells, there is no mention of that type of discharge. You know, they've said profuse white discharge. They've not said it is creamy type of white discharge or creamy gray type of white discharge, and you know, we want the KOH addition to this, which could be releasing the amines and giving that fishy odor. So we want more than 3 to say bacterial vaginosis. 3 out of 4. Remember Amsel's criteria? That's why we say the Amsel's criteria is not satisfied here. That's why it is definitely not bacterial vaginosis. This is physiological discharge. You know, for bacterial vaginosis, we need the Amsel's criteria, which is like the patient is having clue cells, along with that the patient is having a creamy discharge, I'm writing DC, and along with this the patient is having a fishy odor in the secretions. Yes, of course, the fishy odor is more when she's just had sex. Post sexual intercourse, the fishy odor increases, and on adding potassium hydroxide to the secretions, there is release of amines. So these are the 4 criteria, and any 3 out of these 4 or more, 3 or more are required for diagnosis of a, you know, a positive bacterial vaginosis, which is not existing here. Okay, so my answer is D, and that is physiological discharge. Okay, question number 6, an 18-year-old girl with partial, probably that was the term, I'm put a query here because People just said it's a transvaginal septum. Some people said it's a partial transvaginal septum. And she presents to the hospital with dysmenorrhea and chronic pelvic pain. Which of the following is the most common complication? Now, we must understand that if there is a partial vaginal septum, you know what is the level of that? It is quite low because it's the place where the urogenital sinus is going to fuse with the upper vagina, that is 4/5 upper vagina, 1/5 lower vagina. Yeah, of course, the anatomists would like to say, you know, 2/3 and 1/3, doesn't matter, both the systems are in use, and you know, both the systems won't come as different choices in one exam, so don't worry about that. Okay, it'll be either 4/5 and 1/5 choice, or it'll be 2/3 or 1/3 choice. So what I'm trying to say, that the upper vagina and the lower vagina, these are fused to make a complete vagina, but if they don't fuse, then there is a transverse vaginal septum here, and because of that there will be accumulation of blood above this. So accumulation of blood within the vagina, you know, is the hematocolpus, and in the uterus it is the hematometra. So that is the hematometra, and this is the hematocolpus. Now, when we know that there is collection of blood in the uterus, then there could be a backflow. There could be a backflow, and that backflow means that the blood has gone through this and may collect onto various parts, you know, like the ovary, or it may be present over the bowel. That blood could implant at so many places. Yeah, we say that it is endometriosis. So most of the Mullerian abnormalities, they can have some amount of retrograde blood going, because the, you know, defects will come with blockage or with some stenosis, and that will cause retrograde menstruation, which, you know, is the reason for having endometriosis. So yes, tubo-ovarian abscess can happen if these things gets infected, but that's very rare. I mean, you know, I've not seen that as a classical presentation. And dermoid cyst and Thika-Lutein cyst are, I think, not properly recalled choices, but we'll ignore them and we'll answer endometriosis for this MCQ. Okay, so answer is A, question number 7. Now, similar question was asked, or was it two ways of recalling the same question? Never mind, we'll do this question as well. Which of the following is least common in didelphase uterus? You know, didelphase, the two Mullerian ducts have not fused at all. They have given two separate uterus. Now, when there are two separate uterus, we say it is didelphase. It could be with two vaginas, or it could be didelphase with just one vagina like this. So we know that didelphase is known as a bicollis, that is two vaginas and two cervices, or a unicollis, that is one vagina but two different uterus. So that is the didelphase. Now, what is not likely to happen, what is least common in a didelphase uterus? So I'll just show you a picture of one of the specimens in my path lab. You will see that from one side, I mean from behind, you will see there are two fundus here and bodies like this. When you look from here, you may think it's a biconate uterus, isn't it? But if you look at the other side, you will see that yes, there is two separate uterus. You can appreciate like this, you know, and another one like this. So there are two separate uterus, and that is what is a didelphase. That is what is a didelphase. See it, the cervix here. Can you see at this area there is a demarcation nicely. So there is one cavity like this. I'll show with another color. See, there's one cavity like this, and another cavity which is almost completely patent. Now this cavity, if you see, this cavity is not so properly patent here. After that, it is not having, see this, the cavity is looking a little stenosed, probably it is not having a proper flow of menstrual blood when this patient had this uterus. So yes, that's what I'm trying to say, that if there is a Mullerian abnormality, the passages made are not perfect quite a few times, and that's why even in a didelphase uterus, you may see that the fallopian tube may have some amount of blood going like this and causing endometriosis. Not the very common kind of a presentation of didelphase, but endometriosis may be association. So yes, that's what are those are the choices here, that the least common in didelphase, yes, there can be endometriosis, there can be abortions because of small cavity, and there can be preterm labor because of the small cavity, but there will never be a transverse lie. Yes, a breach can be. Yes, baby may present as a breach, or it may present as a cephalic and have a preterm labor or an abortion. But yes, in this small cavities, I doubt if it can ever become a transverse lie. So that's the answer. Yes, I know that I'm giving you an answer a little different from probably what you would like to hear, but see, I've got you proof that this is from Tillin's Operative Gynecology, and it says categorically that in a case of a didelphase uterus is associated with the best possibility of a successful pregnancy. However, there is still some increased chance in perinatal mortality, premature birth, that is preterm labor, breech presentation and cesarean section for delivery, but not of a transverse lie. Okay, so like I said, whatever I would like to teach you, I would like to teach you with a lot of authority and some amount of good references. So when I have got this as a reference, I'm very sure that you people are going to mark that transverse lie is not likely to happen with the didelphase. All right. So please be very confident when you mark this answer. Let's move on and see question number 8. A woman gave birth to twins. The husband says the children do not belong to him. He's probably angry because one of the children is not looking like him. That's what is the story here. That DNA analysis was done and it was found that one child belongs to him, but the other one does not. So what is this a case of? Now, when there are two children born to a mother together, it can be a dizygotic or a monozygotic twin, and here they are trying to say that there are two separate oocytes which are fertilized by two different sperms. So yes, that is a case of superfecundation or superfetation. One of these is the answer here. Why it is not a posthumous child? But because we have not discussed about any fetal death here, there is no such reference here, and there is no forensics involved in this question. And why it is not a supposititious child? Now, supposititious child is a child which is not born to this mother. So that's why it is not a supposititious child. Supposititious child are children which are taken by parents. They did not conceive this child. There was no delivery of this woman. They just go and buy a child. They just get a child from somewhere and then they declare to the world that this is our child. That is a supposititious child. They want to show heir to their family. So when they are under the pressure, especially in our country where they want to have a male child to have an heir in whatever circumstances they can get one from. They might be having, two girls, well-deserving girls at home who are very intelligent and outgoing and entrepreneurs and whatever, but there should be a male to be the heir. So they'll get a supposititious child. So that is not the question here. The question here is between superfecundation and superfetation. So yes, we know that in a dizygotic pregnancy, one oocyte, one sperm, another oocyte, another sperm. Now, how can this happen? That one cycle may have two oocytes. That is what is superfecundity, and there might be two cycles and that may have two oocytes, that is superfetation. Now, superfetation is very important to understand. We have discussed that in the app, but why not once more? Superfetation means that the woman, she actually conceived this month. She actually conceived this month with a fetus which is implanted here, and now she is pregnant next month. In spite of being pregnant, she ovulated. Some freak in a biology, something like a high FSH in spite of being pregnant, and one of the follicles ovulated, and now she has another embryo implanting next month. Now there are two embryos implanted but not of the same cycle. So two cycles and two oocytes, and they are fertilized in the same uterus. So this is superfetation. One child will be born, let's say, at 40 weeks, and that same child, obviously both the deliveries happen together. The second child, which is born on the same day, will not look 40 weeks, it will look around 35, 36 weeks. So you will think that probably it's an IUGR. No, that child is not IUGR, that child is preterm because it was conceived a month late. So yes, that is what is a superfetation. But now let me tell you, I have told you the mechanism of superfetation, but superfetation is a very animal kind of a phenomena. It is seen in cows and buffaloes and goats and horses. It is not very common in humans. So, the literature has given a few cases of superfetation for us to ponder about, but if you go into details of those cases, none of them have been proven beyond doubt. Most of them have still got some doubt in their presentation. So, superfetation is not actually reported correctly so far in literature. So, yes, now you are convinced that the most common type of dizygotic twin is superfecundity. So, yes, there are two children born to this mother, and that is what is superfecundation. And yes, two children can be fertilized. Both the oocytes could be fertilized by the father, but unfortunately one oocyte got fertilized by the father and the second one probably got fertilized by the neighbor, and that's why this father is getting a little upset that this child does not look like me, and he got a DNA done and he was correct that one child is like him, the other one is not like him. So that is a case of superfecundation. Of course, a whole lot of legal issues and a lot of inheritance issues and family issues, divorce, alimony, all that is going to get into this. We'll talk about that some other time. Let's move on. The answer is 8A, superfecundation. Okay, question number 9. A 32-year-old pregnant female with infra-umbilical flattening and fetal heart rate heard in the left flank. Which one of the following will be the most probable presentation? So, yes, most of you know that the fetal heart is easily heard in the left spino-umbilical line. We know that very well because the head is inside the pelvis, and in this line, spino-umbilical line here, in this spino-umbilical line, somewhere here you are going to hear the fetal heart sound. That is what is in the left occipito anterior and the left occipito transverse. You are going to hear the fetal heart here. Now, they are saying that there is infra-umbilical flattening and fetal heart sounds are heard in the left flank again, and they are heard nicely in the left flank. Now, that is what I think it should have been mentioned, that infra-umbilical flattening with a clearly heard fetal heart sound in the left flank. Now, that is suggesting that the heart is much closer to the anterior abdominal wall of the mother, something which happens in this picture which I am showing you. Let's see, the heart is here somewhere and the maternal abdomen is here somewhere, but the back of the baby is here. So, the chest of the baby is near the anterior abdominal wall of the mother. So, you can hear this sound so easily, the heart sound so easily. Now, that is what is a occipito-posterior. See, the occiput is posterior. You can see the sinciput in the front, and this is a case of occipito-posterior. You see, you can easily hear the heartbeat here. So, this is occipito-posterior. Dorso-anterior. Dorso-anterior means the back is anterior. So, when the back is the presenting part, then it is a transverse lie. Okay, and brow of course is not this, and this is not occipito-anterior. They are trying to tell you occipito-posterior position. So, this is the most common malposition. Most common malpresentation is breech. Most common position is left occipito transverse, left occipito anterior. Most common malposition is right occipito posterior. All right. So, that is what we were trying to tell you. Now, let us look at this, these diagrams of the pelvis here. Now, the most common type of pelvis is the gynecoid pelvis, and the second most common is the anthropoid, third most common is the android, and the rare type is the flat pelvis or the platyploid. Now, anthropoid and the android. Anthropoid and the android are the ones which will have occipito-posterior. OP can come here and OP can also come in this one. So, I am trying to make an arrow. The arrowhead is the fetal head. I am trying to make the arrowhead to show you the fetal head, and the arrowhead is actually the occiput. So, if this is occipito-posterior shown by the arrow, then there is not much place for the head to rotate. I will show you the different color here. See, this rotation here which you want the head to have and come and become occipito-anterior, there is not much space in anthropoid because there is sideways narrowing. Now, in a case of android, this motion can happen, the sideways motion can happen, and the baby can become occipito-transverse. Now, for it to become occipito-anterior, this rotation is not possible because there is narrowing in the front. The pelvis is narrow from the front. It's a male type of pelvis, the android. So complete rotation is not possible. It rotates to transverse. Occipito-posterior can rotate to transverse. What you can do? You can put your hand, hold the head and make him turn that remaining 45 degrees. So yes, in this case, which is now in a transverse, occipito-transverse, you can do a manual rotation and a forceps extraction. Manual rotation, forceps extraction can be done in a case of a android pelvis, where part rotation is possible by itself. It will go into occipito-transverse. Mind you, it can get stuck in deep transverse arrest. Yes, it may be too deeply impacted and the mother might go into dehydration and the baby might have a very big caput. It's a deep transverse arrest and you cannot disengage it with your hand anymore. So go ahead and do a cesarean. But before it's a deep transverse arrest, you can hold the head and rotate the head and make him occipito-anterior, and that is known as the manual rotation. Along with that, you can do a forceps extraction. So yes, it is possible to do that in android, but not in anthropoid. In anthropoid, it stays occipito-posterior. So it will stay occipito-posterior. We call it persistent OP, persistent occipito-posterior. So the delivery happens by phase 2 pubis. Very important. These are all terms which keep coming in your exams. The delivery in this case happens phase 2 pubis. See, if this baby comes out of the pelvis, his face will be upwards towards the symphysis pubis. So yes, occipito-posterior, which stays persistently occipito-posterior, delivers phase 2 pubis, and the one which can turn and become anterior, that may require a good gynecoid pelvis. Otherwise, even an android pelvis, it may happen, and that will require manual rotation, forceps extraction. All right, let's go and see question number 10. A 22-year-old pregnant lady at 36 weeks period gestation with painful reddish vesicular lesions on the vulva. What is the management? Now, painful reddish vesicular lesions in the vulva, that is suggestive of zoster, herpes zoster, and these lesions may get to become infective because some of these blisters can rupture and then it can become infective to the fetus also. Otherwise, most of the time, they don't cause much infection. A reactivation of, varicella infection. Reactivation of varicella is coming as shingles or, zoster. So this reactivation is not going to be mostly particularly infective to the baby. All right. Mostly it does not cause that. It causes a lot of pain to the mother. We know that. So yes, in these conditions, what are you going to do? Now, please be very careful. They're asking you about zoster. They're not asking you about active chickenpox in the mother. Okay, so I'll be discussing that a little bit here, but they're asking about zoster. So acyclovir in elective cesarean section, no way. You don't have to do a cesarean section. See, in zoster, we don't say doing a cesarean section is going to reduce the infection. Okay, zoster, you do vaginally or do a cesarean. Both ways the infection can transmit or may not transmit at all. Okay, so induction of labor. Why do you want to take a risk of spreading infection? She's only at 36 weeks. In fact, when there's anything active happening in the body and you have time, see, it is 36 weeks. Why not wait for at least 1 week so that the mother makes antibodies and those antibodies are transmitted to the baby if it is active varicella. Okay, but this is most likely a reactivation. So never mind, I'm not going to do a induction of labor at 36 weeks. Definitely acyclovir and allow spontaneous progression of labor, or was it pregnancy? I think we are trying to say that give acyclovir and allow the pregnancy to continue. You don't have to terminate it because she'll get better with the condition. Okay, antibiotics and pain medication, I think, is a recall choice to just fill up the choices. I don't think that was the choice here, but anyway, antibiotics and pain medication can also be given, but definitely not the procedure of choice because acyclovir has to be given. So answer to this is C. Acyclovir is given around 10 to 15 milligrams per kg every 8 hourly. All right. So now I'll just tell you a few facts about the varicella, infection causing pneumonia. So risk factors for varicella zoster, the virus. So risk factors for varicella zoster virus pneumonia include smoking, and having more than 100 cutaneous lesions. So, if that many lesions are there, then it is worrisome. Congenital varicella syndrome rarely develops in a case of maternal herpes zoster. Like I told you, zoster is contagious if blisters are broken, and less so than with primary varicella. Okay, much lesser. It is much lesser than primary varicella. You must remember that. Okay. Now, primary varicella, if at all they ask you a question, I thought might as well finish off this also. Primary varicella, that is chickenpox during pregnancy. That's the meaning of primary varicella. Primary varicella during the first of pregnancy may develop a congenital varicella syndrome. Mind you, in which half? Between 30 to 20 weeks. Before 13 and after 20, it's not of much problem. Okay, this MCQ has come so many times that I was, convinced that I'm going to, tell you a little bit about this apart from telling about the shingles or the varicella zoster reactivation which we were discussing just now. So yes, in a person who's having active varicella in the first of a pregnancy, especially 13 to 20 weeks, that is the one which is going to cause problems to the fetus. So what are the problems? That is the congenital varicella syndrome, chorioretinitis, microphthalmia, cerebral cortical atrophy, growth restriction, hydronephrosis, limb hypoplasia, and cicatrical skin lesions. Okay. Now, neonates born to mothers who have clinical evidence of varicellas before 5 days of delivery and within 2 days after delivery. Now, that is the worst time for a baby to deliver. If she is having active varicella, that is active chickenpox, just before delivery or after delivery, then maternal antibody has not been formed, and the neonate face almost 30% of mortality in these conditions, may develop disseminated visceral and CNS disease. So, varicella zoster immunoglobulin VZIG should be administered to the baby newborn. Alright. So, let us see question number 11. A 32-year-old female presents to the hospital with cannonball appearance on the chest X-ray. That's suggesting some secondaries to the lung. Patient had a history of molar evacuation. Which of the following is the best management? Now, we say when there is a molar evacuation, a molar pregnancy, a vesicular mole can become a choriocarcinoma in something like, up to 15 to 20% cases. A partial mole can become a choriocarcinoma, something like 1 to 3 or maybe 2 to 4% of cases. Now, that's why we follow up the HCG whenever we do a vesicular mole evacuation. Now, they are saying that there is a condition after molar evacuation that some trophoblastic tissue has persisted and it isn't found its way into the lung. So, there is a metastasis to the lung. Now, lung metastasis is bad, but it is the primary metastatic site. So, that's why involvement of the lung is stage 3. Any other site of the body is stage 4 apart from the pelvis. So, in the uterus it is stage 1, in the pelvis it is stage 2, in the lung it is stage 3, and any other site is stage 4. So, from the uterus, suppose it goes to the bowel like sigmoid colon, then it becomes stage 4. So, disease confined to the uterus, disease extending outside the uterus but limited to the genital structures, and gestation trophoblastic neoplasm extend to the lungs and all other metastatic sites. So, that is the stage of those are the stages of choriocarcinoma or gestation trophoblastic neoplasm like we are discussing. Now, apart from this, in gestation trophoblastic neoplasm, we have a prognostic scoring. This is the one which is given in Novak's Gynecology, and we have 9 factors which we keep into account. This is actually the WHO scoring which is modified a little here. So, the age of the patient and antecedent pregnancy, suppose it's a term pregnancy, it's much more worse prognosis than a hydatform mole. This patient is a hydatform mole, it's a vesicular mole. So, actually the score given is only 0 for this one. So, interval between end of antecedent pregnancy and start of chemotherapy, human chorionic gonadotropin levels, ABO blood group association, B groups getting more problems than the ones not having B, largest tumor size, site of metastasis. Now, site of metastasis, spleen, kidney, GI tract, brain, liver. See, lung they have not even mentioned here because lung will not get any score. Number of metastasis, and that is just one here, one site, and prior chemotherapy. So, this is the WHO prognostic scoring system, and by this, if it is less than 7, we say it is low risk, and more than 7, we say it is high risk. Now, the case at hand, we are discussing that the patient's lesion has gone to the lung. So, yes, you may think it's a metastatic condition and it is stage 3. Now, between stages 1, 2, 3 and 4, 1 we know, stage 1 we know is low risk, stage 4 we know is high risk. That is very clear. So, 1 is clearly a low risk, 4 is clearly a high risk. Now, the problem is between stage 2 and stage 3. Now, stage 2 and stage 3, we need to use this scoring system nicely and put stage 2 and stage 3 into low risk or high risk. Now, how does that happen? With this prognostic scoring system, and your patient has just one metastatic site, and that too to the most common metastatic site, which is the lung. The score is actually 0. So, this is a low risk stage 3. So, low risk stage 3, that is typically lung metastasis with low risk. It is given straight away in Novak's gynecology that they will respond to single agent chemotherapy. Alright, so there is no need of giving a combination chemotherapy. Straight away it's given. A little complicated question. I think that was a question because that's how it was recalled and given to me. Little complicated, and I'm sure that you people would have read this but not in so much of detail. So a single agent chemotherapy like methotrexate is the answer here. I will have to go with 11C. Okay, radiotherapy is not the primary treatment for trophoblastic tumors, because when there is choriocarcinoma, it responds beautifully to chemotherapy management. While I'm discussing with you, there are a few patients who come to my mind which we have given chemotherapy with choriocarcinoma. They have done so well that the same uterus which had a cancer like a choriocarcinoma has got pregnant and given deliveries of normal children. So yes, we have to go and say that chemotherapy is the foremost and the frontline treatment of choriocarcinoma. Yes, if she's completed family, I can do surgery also. Combination chemotherapy is MAC, that is methotrexate, actinomycin and cyclophosphamide. Along with that, using etoposide and also using oncovin. So I don't think it is the regime which is required for this simple case of low risk metastasis. Okay, yes, I know it is stage 3, but it is low risk. Okay, so answer to question number 11 is C. Let's go on to question number 12. 25-year-old primary graduate, after giving birth to a child, has continuous bleeding from the uterus. They're suggesting a PPH which is not getting managed here. The patient was taken to the operation theatre and planned for a uterine devascularization. Which of the following is the correct order of devascularization? That is, you want to take out the blood supply of the uterus and you want to make sure that the bleeding stops before you end up doing a hysterectomy. So, you want to probably prevent a hysterectomy by stopping the blood flow. So, yes, you know what is the immediate artery which is supplying blood to the uterus? That's the uterine. So, yes, that's the one which you ligate first. And uterine gets a good anastomosis from the ovarian. So, you will go to that one next. And then uterine is a branch of the internal iliac artery. So, I must go with answer C. I don't think obturator and vaginal artery and external iliac artery ligation is going to help. So, these choices are giveaway that I'm not going to use those. This one and this one, they are not the choices which I'm going to mark. So, answer is C. Uterine, ovarian artery and internal iliac artery. So, these are the branches. So, first of all, I'll show you that if you see the uterine artery here, see this is the uterine artery. It has this good anastomosis with the ovarian artery. So, that's why I'll ligate the uterine here, the ovarian here. So, that's the anastomosis which is supplying a lot of blood, and if that doesn't work, then I'll go a little bit above and ligate the anterior division of the internal iliac artery here. This is coming again in a lot of discussions in the MCI exam and in the NEET exam once more. The blood supply to the pelvis. The major artery to the pelvis is the internal iliac artery, and anterior division has more branches. Anterior division has the uterine artery branches. So, we will ligate only the anterior division. Hello, what are we going to do? We are going to put a snug ligature, a ligature which is tight enough to reduce the flow. It is not going to be a crushing ligature which is going to stop the blood supply. Mind you, we are just reducing the flow by this ligature. Okay, we are not stopping, we are not cutting off the flow. Reduced flow makes the flow in the uterine bed sluggish. Sluggish flow promotes thrombosis, and that's how the bleeding stops. We are not totally stopping the blood supply. So, be very careful when you are talking about the divisions of the internal iliac artery and the principle of ligation of the internal iliac artery, and why you should not be ligating the posterior division by mistake. That was also a question recently. And if you ligate the posterior division, see the posterior division is here. I'll just show you clearly. This is the posterior division here. So, if you ligate that, then the superior gluteate artery, that artery is also going to reduce the blood flow, and that is going to cause certain amount of ischemia to the gluteus area and cause gluteal pain. So that was the question which came in your MCI exam. I'm sure a lot of good questions are coming in the MCI exam. So all of you guys, please keep revising the questions from the NEET exam, but also from the MCI exam. Good practice hints. All right. So for this question 12, answer is C, which I've already marked. That is uterine artery, ovarian artery and internal iliac artery. So the next question I'm going to take is question number 13. A 34-year-old lady using oral contraceptive pills for 5 months presents with amenorrhea since 6 weeks. Which of the following is the best to calculate the gestational age in this case? Now, a woman was taking oral contraceptive pills for 5 months prior. That is, for good 5 months, she had regular cycles. That means she knows when her cycles were coming and she was very sure that when she stopped the pill, when she got the next period. So this is something called the good dates. You know, what are good dates? When the patient is very well aware of her periods, or she was taking oral contraceptive pills, so she knows that when her periods have come, or she's had a ultrasound in the first trimester which correlates well with the gestational age. So these are good dates. Okay, that's how we say this patient has good dates because she was on pills, and when she stopped the pills, she conceived. Immediately before she conceived, she was on oral contraceptive pills. These are good dates, like we say. So good dates, I'm sure, okay, whatever is the LMP, I'm going to add 9 months and 7 days. So that's what is 280 days from the LMP, which is also known as the 9 months and 7 days, which is also known as the Naegele's formula. Naegele's formula, or it is that 40 weeks calculation, all right. So you people know that very well, and the others are not to be even discussed because it's a straightaway simple question where they've asked you what is a good date. When you know OC pills have been taken and now she's conceived, then she's very well aware of her ovulation, because so when she's taken combined oral contraceptive pills, she's very well aware of her date of periods. Okay, so let's move on. Question number 13, answer is A. Question number 14. What is the modality of the test used here? Now, I don't know whether they asked you such a simple question. I mean, that's an absolute sitter. I mean, if you were in third year, you would have answered this question without any problems, I'm very sure. So, yes, they have shown a cannula. A leech cannula is in the uterus, and in the uterus, you can see there is some amount of beading. So, I thought one of the questions which I'll show you some beading of the tubes. Okay. So, yes, there is a beading of the tubes. It's a beaded tube, and this test is a hysterosalpingography, no doubt about that. It's not a laparoscopy. You will see tissues, pink and yellow tissues, and it is not a hysteroscopy. You will see things from inside the uterine cavity, again red and pink, and it is not a saline infusion sonography, because when you're doing a saline infusion sonography, you will see an ultrasound picture, isn't it? So in an ultrasound picture, you will have that saline infusion sonography means that we put a cannula into the uterus like this, and with that we instill some fluid. So we want to see if the tubes are patent. Okay, so we instill some fluid, and that fluid, when it goes out of the fallopian tube, it collects in through the pouch of Douglas. So when you're doing an ultrasound, you can see the uterus, and there's a cannula. Okay, see, this is the uterus, and we put in a cannula here into the uterus, and I put a ultrasound machine on the abdomen of this woman. So when I put in some saline, that saline will go into the uterus, and if the tubes are patent, it will also collect in the pouch of Douglas. That is, you will see an indirect evidence that you put in some saline in the uterus. You cannot see the tubes on ultrasonography, but when you put the fluid into the uterus, some fluid increases in the pouch of Douglas. That means, okay, fine, the only communication between the uterus and the pouch of Douglas is the fallopian tube. That is probably patent. That's why the fluid is collected in the pouch. So that's an indirect evidence of tubes being patent, and that is what is the saline infusion sonography. But yes, in this one, straight away the answer is a hysterosalpingography. All right. So question number 15. A 25-year-old female with primary infertility came to the hospital with ultrasound findings of uterine anomaly. Which of the following is used to confirm the diagnosis? Now, if there is a uterine anomaly, then the best imaging, what you can do for getting a near perfect result is MRI, but then that was not given here. Which of the following is the best to confirm the diagnosis? Overall, even better than imaging, even better imaging than MRI, the best investigation is to put in a scope and see the uterus from the top, and then put a scope into the uterus and see it from inside. Now that is the best way to assess a uterine anomaly. A laparoscopy along with a hysteroscopy. TUS is good, that is the initial investigation. Laparoscopy alone is not good enough, and HSG at most is a preliminary investigation. Okay, so when it is given as a straightforward MCQ, please go ahead and mark laparoscopy and hysteroscopy is the best way to assess the anatomy of a woman who is trying to have a conception. So I'll show you a couple of pictures here and a video here. You see, this is what is a laparoscopy, and when I've put in the scope here, I can see the tube nicely here. I'm lifting up the uterus and showing you the pouch of Douglas. I can see the tubes nicely, and I can see the ovaries here, see here, and the tubes here. So I'm very sure that this is the best way to assess the anatomy of a woman who has got infertility. All right. See here. Very nicely seen the anatomy. Along with that, we can also see the relation of the bowel with the uterus and the tubes. Okay, now in the same sitting, we can also inject some dye. I'm looking at the uterus from the top, and my assistant is putting dye. See, some dye has come, blue dye is collecting the pouch from the right tube. But then yes, left tube, I was a little worried, and I was trying to see if something is coming. Some fluid I thought was coming out from the fallopian tube, but it was some blood which was trickling, and it was not the dye. It came, see, I'm trying to repeatedly squeeze the fallopian tube and push out some dye, but that won't happen. So there is some collection of dye in the fallopian tube in the left side, but it's not coming out. So probably there was a block in the left tube, and the right tube was showing this good amount of dye coming. So this way I can know the anatomy of the pelvis, see the tube ovary relation, and if there is some addition of the tube with the bowel. So all of that information can be derived by a laparoscopy, hysteroscopy nicely. So let's see what is seen in a hysteroscopy. See, I'll show you. This is a hysteroscopy. We are seeing the endocervix. First, little blurred here in the initial time always. Then when the fluid starts flowing properly, you can see in the hysteroscopy well. So the endocervix looked good to me. I'm showing that again to you. Now when I get into the uterus, I would want to see the fundus of the uterus and the ostia. So see, there is one ostia here. If you can make out, that is one ostia here right now. And then I'm going to turn the sheath of the hysteroscope and show you the other ostia. This is nicely seen in this one. So now we come out, and that's the panoramic view. From a distance we can see the uterine cavity. So the things which were floating all over the uterus, that was the endometrial glands. This was being done in the premenstrual phase. So a lot of endometrial glands, they start breaking and come into your view, and they'll be floating like that. So don't worry, that's nothing abnormal with this hysteroscopy. We are trying to show the ostias, the fundus, and the endocervix. That's the assessment by the hysteroscope. Another hysteroscope picture I'm trying to show you here. This is a movie where on the hysteroscope I'm seeing a large based fibroid. So while I'm doing a hysteroscopy, I can also correct a defect. That's why it is a nice way. This looked like a polyp to somebody who had sent me this picture through the MRI. So I was doing this hysteroscopy, and I thought that this didn't look like a polyp, and now I was correct because it was a fibroid. It was a type 1 fibroid. Can you see? Type 1 fibroid, which is stuck to the uterus, but mostly more than 50% it's inside the cavity. And I'm just teasing off the base with this instrument. It's a bipolar cautery. It is known as the Varsa point, and with that I'm just shaving off the base and putting up this fibroid. So that's why I was trying to say that if you do a hysteroscopy and a laparoscopy, you can see uterine defects, and you can see these small things which keep popping out undiagnosed, but them also you can take care of at the same time. Okay, so we'll see question number 16. A 25-year-old female presents to the hospital with a midline septum in uterus. Which of the following is the management of this condition? Now, midline septum. Now, they have given you the diagnosis. Just now I told you the best way to confirm the diagnosis is through a laparoscopy and a hysteroscopy. Now, when you see the midline septum, what is the best management? Now, the septum is, jutting into the uterine cavity. It's relatively lesser vascular as compared to the other parts of the uterus. So it can, when a pregnancy implants here, it will not have a good blood supply, and that's why the pregnancies don't implant properly in this area. It can cause infertility also. It can cause a transverse lie and a preterm labor. It can cause an abortion. So that's why these septums have to be removed. So laparoscopic metroplasty, obviously not. You're not going to enter the abdomen here and cut the septum. Hysteroscopic septoplasty, yes. his uterine metroplasty. Metroplasty is, cutting the uterus into two halves and then joining them. That's too extensive a surgery for a septum like this. So, I am going to stick with a hysteroscopic septal resection or septoplasty as mentioned here. So, I am going to just get inside and shave off this with a similar instrument which I was using in the previous screen. That is a bipolar cautery. That's my favorite instrument by which I work, and a bipolar cautery can just shave off this septum. So, I would like to add here that most of these biconate uterus which you see on a hysterosalpingography turn out to be septums. Of course, there is a lot of information which is there on the internet, and a lot of MCQ questions keep discussing that what are the angles between the cavities, whether it is more than 105, it is biconate, it is less than 75, it is septate, and the distance between the two cornu, if it is more than 4 cm, it is biconate, and if it is less than that, it is septate. So, there are so many things they keep discussing, but as a clinician in practice, every time they say it's a biconate uterus, it turns out to be septate. The only way I can convince you people is that I don't have a count of the septums which I've done in my life. Seriously, I keep telling this in my classes also, that till 2010, I had gone way beyond 200, 300 septums. After that, I've stopped counting. But I have yet to do, unification of a biconate uterus. I've seen a lot of biconate uterus. They don't cause much problem. They come at term with probably a breach or a transverse lie, and they're not half as common as septums. So, yes, that's what is, speaking like a clinician, I'm telling you that septum, yes, is the most common Mullerian defect, and that's also one of your MCQs. Let's move on and see question number 17. A 55-year-old multigravida with history of frequently micturating due to coughing, laughing and sneezing. What is the diagnosis? So, every time she increases her abdominal pressure, some urine comes out. That is classical stress urinary incontinence. I don't know why they gave such a simple question. So, you know that the angle of the bladder with the urethra is something like this. It's around 80-85 degrees, isn't it? So, if there is straightening of this angle, more than 110 degrees, this angle, if it is straightened, all right, I made it rather too straight here, but I think that is going to convey the message well, that when there is straightening of this angle, then there is easy passage of urine because the uretrovesical angle is straightened, and whenever the woman coughs, then the pressure of the abdomen is transmitted to the pressure of the bladder, and that overcomes the urethral resistance easily and urine slips out. So, it's an anatomical defect which can cause a stress urinary incontinence, seen very commonly with prolapse. So, stress urinary incontinence, yes, they can be urge incontinence, but urge incontinence not coming with coughing, laughing and sneezing. So, and UTI can cause some amount of incontinence. Yes, it is known to happen with a lot of young girls also. When they have severe UTI, some urine can come out, but that's not related to again cough, laughing and sneezing, isn't it? So, urinary incontinence, some amount of dribbling can happen with very severe UTI. Some amount of dribbling keeps happening with the severe UTI. But yes, neurogenic bladder, now that's a complicated kind of a choice they've given here. I hope it was the choice, but the neurogenic bladder, is there are types of neurogenic bladder. Some of them are too spastic, and they contract overactive. Spastic and overactive, that is that even with less amount of urine, they go into contracture, and that bladder will empty urine frequently because of a very active overactive bladder or a spastic bladder. And sometimes these neurogenic bladders are flaccid, so they'll keep filling and they'll not empty at all. So that is the underactive or these flaccid kind of a neurogenic bladder. So, I'm sure the medicine people will teach you very well about that. So, for the time being, I'm just telling you this is a straightforward stress urinary incontinence. 17, answer is B. Okay. Now, question number 18. A pregnant lady was given indomethacin for the treatment of pain. Which of the following can be likely outcome in the baby? Now, they have not given the details, indomethacin for pain. So, if it is beyond 32 weeks, they say that if you want to give indomethacin for pain, or if you want to give it for preterm labor, indomethacin is also a tocolytic. Then whatever you do, you should give it before 32 weeks. Indomethacin also reduces the urine output. So, yes, pain is one reason why you give indomethacin. Then for preterm labor, it works as a tocolytic, and also for reducing liquor in a case of polyhydramnios, it is helpful. So, preterm labor treatment and reducing liquor, indomethacin can be used, but whatever indication you use, not after 32 weeks, because that indomethacin can cause the ductus to have a premature closure. So, premature closure of the ductus arteriosus. So, premature closure, not patent ductus arteriosus, premature closure of the ductus arteriosus can happen. That is why indomethacin is not given much beyond 32 weeks. Answer is B. Now, question number 19. A female patient on antihypertensive drugs comes for preconception counseling. Which of the following drugs you will advise to stop? Some of these pharmacology questions were related with pregnancy, so they were forwarded, and I am sure the pharm faculty has discussed this wonderfully with you that any AC inhibitor is contraindicated in pregnancy. Between methyl-dopa and nifedipine, there is not much of a problem, but yes, atenolol can be given in pregnancy if there is a requirement, because it is one of the safer beta blockers to be tried in pregnancy. So yes, I won't say it is the best drug for antihypertensive management, but between atenolol and lisinopril, I am very sure that you cannot give AC inhibitors. They cause IUGR, and then they cause hypocalvaria, and they can also be related to renal agenesis in the fetus. So, definitely not lisinopril. So, that is the answer to this question. Question number 19, C. Question number 20. A lady presents with a pregnancy of 6 weeks. On ultrasonography, a left adnexal mass of 3 centimeters is noted. The mass has a small gestation sac and a fetal node, but no fetal action is seen, no fetal heart action is seen. What is the management? So, they are trying to say that there is a pregnancy of 6 weeks. And ultrasound, you can see the sac and you can see a fetal node, but no heartbeat so far. They cannot give such a straightforward question about ectopic pregnancy, because you know that based on this we can think of medical and surgical management. So, we can say medical management by, let us say, methotrexate or by KCL or actinomycin, and we can say surgical management by a linear salpingostomy. Linear salpingostomy, okay. No linear salpingotomy anymore, that is not done. Linear salpingostomy, make a hole in the tube, that is it. So, linear salpingostomy and a resection anastomosis. These are the surgical options. Now, these are based on the information that the size of the sac is 4 centimeter, less than that medical management, more than that surgical management. If the HCG is 5000, more than that surgical, less than that medical. And cardiac activity, if it is present surgical, absent medical. So, based on this information, we can decide whether you want to do a medical management or a surgical management. Now, this is exactly how it is given in Novak's gynecology. And I don't know, those who have been reading my, my notes that have been associated with me for a while, you will understand that this is what we've been telling you for so many years, that HCG less than 5000 is best managed medically. More than 5000 also people manage medically, but the success rate is much lesser. So, yes, less than 5000 HCG and less than 4 centimeter size of the ectopic pregnancy is best managed surgically. So, yes, less than 4 centimeter size and HCG less than 5000, that is what is best managed medically. More than that, go ahead and do a surgical management. Alright, so the answer to this question is a medical management. Now, wait and watch, conservative management, see, these are things which are very controversial, and I don't think these would have been the choices. Conservative management is done only when you see HCG value less than 1000 and you know that you are not able to see a sac, then, or a sac is not growing, the HCG value is reducing, then you can think of conservative management. But don't think of conservative management, either medical or surgical. Commit for a ectopic pregnancy, that is what is better. Okay. Now, let us move on and see question number 21. A lady with primary infertility was diagnosed to have 2 uterine fibroids in the cornal region. Right side is 7 into 5 centimeters and a left side mass is 5 into 4 centimeters. So, let me draw that and see what is happening here. So, there is this fallopian tube here, and somewhere on the cornu there is a 7 into 5 centimeter mass, alright, and on the right side there is a 5 into 4 centimeter mass. Okay, both the tubes are found to be blocked. Obviously, if there is a cornal mass, the tubes will be blocked. What's the management if you are told that the woman is ovulating and the semen analysis of a partner is normal? That is, the female factor is ruled out, that she is ovulating, she is healthy, and the semen analysis is good. Now, the only problem is a physical problem here. So, on HSG, both the tubes are found to be blocked. Of course, they'll be blocked. There are such big fibroids sitting on the corner, they will be blocked. What is your management if you're told that the woman is ovulating? That means the other part of the physiology is well, and the semen analysis of a partner is normal. Alright. So, the only problem in this woman is that there are these big fibroids sitting on the uterus. What are you going to do? I'm going to remove the fibroids. That's all. I'm going to remove the fibroids and hope that the tubes are patent, and probably give her an intrauterine insemination later on, or probably just give her a trial of observing the fertile period. That is, I take out the fibroids and 3 months later, not before 3 months, some people say 6 months. 3 months or 6 months later, she can conceive by normal intercourse or by just fertile period observation, or I can probably do a intrauterine insemination. Didn't like the answer? I know some of you are hoping that you'll do an assisted reproductive technique. Just because assisted reproductive technique is there, I'm not going to fall for that, because you must understand, if you put in an embryo here, you think it's going to stay inside with such big fibroids? So much of contractions are going to happen and she's going to eventually abort with these fibroids. So yes, when there is a fibroid of this size, haven't you learnt about the management of fibroids is to remove the fibroids or shrink the fibroids? You cannot ignore what are the symptoms of fibroids. What are the main symptoms of fibroid? We always say pain, bleeding, and the third one is infertility. These are the main symptoms of fibroid. And when she's come to you with infertility, what are you going to do? Leave it alone and treat the infertility in another way, given assisted reproductive technique. I don't know why some of you were telling me that it is ART. I'm sure most of you are convinced now that when you do assisted reproductive technique, it's an expensive technique and you're going to give an embryo into a uterus which is already compromised. So yes, I'm going to take out the fibroids, and if the tubes are going to be still blocked, fine, I'll go ahead and do an assisted reproductive technique. But I'm going to do the first management, and that's the best management and the management of choice, whichever way you want to hear it. And that is to take out the fibroid first. So I'll do a laparoscopic myomectomy, or they've not given that option, they just said myomectomy. Fine, I'll do a myomectomy and make sure that the tubes are patent. I'm going to do a bloody good job here, isn't it? I'm going to make sure that it's going to be a patent tube, and if it is not patent, I'll then think of doing a assisted reproductive technique. As simple as that. So please don't do an ART on a uterus which is already compromised. Fibroid causes infertility. That infertility is happening here. Take out the fibroid and then treat the infertility. I'm sure you just take out the fibroid, she'll be cured of the infertility. Alright. So that's the answer to this question. We'll do a myomectomy. Alright. So answer of 21 is C. So there were a lot of good questions here and a lot of discussion happened about them, and a good mix of obs and gynae. But then if there were any questions which I've missed in this discussion, you're always free to send them to me in the PrepLadder Premium Club, or you can send me an email at drprassan@yahoo.com. Alright, keep reading very hard. Best wishes.